My name is Sarah Kaminer Borland, and I'm with the HHS Office of Intergovernmental and External Affairs. Thank you again for joining us on World Diabetes Day and during Diabetes Awareness Month, a time to raise awareness about the diagnosis, prevention, and treatment of type 1 and type 2 diabetes, conditions that affect 1 in 10 Americans. We're joined today by Dr. Meena Seshamani, the Deputy Administrator at the Centers for Medicare and Medicaid Services, or CMS, and the Director of the Center for Medicare, and a panel of consumer health equity and provider advocates. Before we get to our panel of experts, I want to start with a couple of questions for you, Dr. Seshamani, who is leading the implementation of our historic new law that's transformational for many patients, but carries a special significance for people living with diabetes. So before we talk about the specifics of the new drug pricing law, Dr. Seshamani, I want to talk about the population you serve at Medicare. One of the goals for this discussion is raising awareness about just how prevalent diabetes is in the United States, especially among older adults. Can you give us a sense of how many people in Medicare have diabetes and why access to affordable drugs for their condition is vital?
Well, thank you so much, Sarah, for having me here today. And it's great to be here celebrating World Diabetes Day and diabetes awareness, because as you said, awareness is key for us to be able to care for everybody who has diabetes. You had mentioned that 1 in 10 Americans have diabetes. Among older adults, it's more like 1 in 3. And that's why it's so important that everything that we do in the Medicare program is really geared towards improving care for diabetics. In fact, of people in this country who take insulin, half of them are on Medicare. So really, again, there's just a huge prevalence of diabetes in the Medicare population. And that's why this issue is so important to me, leading the Medicare program. And, you asked about why is access to affordable drugs vital? Before I took this role leading the Medicare program, I was leading care transformation and taking care of patients at, a large health system. And one of the services under my purview was our diabetes care management program. And the number of people who would say that they could not get their diabetes under control because they could not afford their insulin. It was a real issue. And it is huge that now, thanks to the new drug law, that nobody has to pay more than $35 a month for a covered insulin product in the Medicare program. I travel the country and do roundtables with seniors. There was one woman in a roundtable that I went to who was giving her brother money every month so that he could afford his insulin. This is an issue that doesn't just affect the person with diabetes, but it affects families and it affects communities. And as you all know, if you are not able to take your insulin, if you're not able to take your medications, then it's hard to manage your diabetes. And there are all sorts of complications that can result, from heart complications to nerve complications, amputations. And so it is so important that we are doing everything we can to keep people healthy, to keep them well. And that's why, making drugs more affordable is a critical part of this.
Thank you so much. And I want to invite you to expand more on what is in the President's new lower cost prescription drug law, the Inflation Reduction Act, and how it really advances access for people living with type 1 or type 2 diabetes.
Yes, and it is really the privilege and the opportunity of a lifetime to be able to bring these changes to the more than 65 million people who rely on the Medicare program. And as I mentioned, 1 in 3 of them have diabetes. So we talked a little bit about the $35 insulin copay cap. So that is in effect already this year, where no one on Medicare with Medicare prescription drug coverage has to pay more than $35 a month for a covered insulin product. Also, this year went into effect $0 for recommended vaccines. Again, very important for people with diabetes. People with chronic illnesses tend to get sicker, and it's so important to be able to get the RSV vaccine, to be able to get, flu, etc., to be able to get all of these vaccines at no out-of-pocket cost. Shingles is another very important one where people were spending $200 for a shingles vaccine, and now you don't have to spend any money for those vaccines. Coming up, starting January 1st, 2024, there are two other big changes coming. First, we are expanding the financial assistance program for prescription drugs. It's called the Extra Help Program. So that is huge for people of lower resources who have trouble affording their medications. And second, for people who have high cost drugs where they reach what's called the catastrophic phase of their prescription drug benefit, they will no longer have to pay anything out of pocket once they hit that threshold. That's the first time in the Medicare program that there has been a limit to what people can pay out of pocket. And that also starts on January 1st, 2024. And this leads up to, in 2025, a $2,000 out-of-pocket cap on prescription drug costs in the Medicare program. So nobody will have to pay more than $2,000 out of pocket in a year for covered prescription drugs, which is a first for the Medicare program to have that kind of a limit. And it's so important for everyone to know these changes because right now we are in Medicare open enrollment. I would be remiss not to mention open enrollment where I have the chance. Between now and December 7th is the time for people with Medicare to evaluate their options and find the option in Medicare that works best for their health needs and their financial situation. So given these changes, given the extension of financial supports, thanks to the new drug law, given the change in no more out-of-pocket costs for those really high-cost drugs when you hit that catastrophic phase, it's so important for people to go to Medicare.gov or call us at 1-800-MEDICARE so that we can help you to figure out what option works best for you. And this is so important for people who have a chronic illness like diabetes, that it's so important to be able to stay healthy.
Thank you so much. And thank you for highlighting. That's a lot of historic first. And so it's a really good reason to make sure you're enrolled in the right plan for you and for highlighting the importance of all these provisions beyond insulin, because so many people who have diabetes may have another condition and it's important for them to prevent illness as well. So thanks for highlighting those. Beyond the president's new drug pricing law, can you share more about other programs CMS is engaged in order to advance accessible, quality care for those living with diabetes?
Absolutely. And actually, before I do, there's one other really big provision in the new drug law that I should mention. Another first. Medicare, for the first time in its history, is negotiating directly with the manufacturers of 10 selected drugs. And 4 of those drugs are drugs for diabetes. So here also being able to negotiate directly to reach a fair price for people with Medicare who rely on these drugs for their health and for the Medicare program. So I want to mention drug negotiation as well. Moving now beyond the new drug law, there are so many things that we are doing in the Medicare program to really try to make sure that Medicare is caring for people rather than just treating a disease. Sarah, as you mentioned, people with diabetes have other things going on in their lives. We all know that the communities in which we live, there are many things that impact our health. And it's so important as a health system that we really take care of people's health rather than just treating them when they get sick. And there are a lot of changes that we're making in Medicare to really try to advance that. So, for example, we recently created payments for community health integration. So if someone has a health-related social need like food or housing, we can pay a healthcare provider that is addressing those needs as part of a care plan. We are also starting payments for care navigation for serious illness, which can directly benefit people with diabetes, because we all know when people have very serious illnesses, it can be hard to navigate the system, and that can lead to people falling through the cracks, not staying healthy, getting sick. So this is all part of what can we do to make sure that we are keeping people healthy, and that is a smarter way to spend money in the Medicare program to achieve our goal of improved outcomes. And we are also going to be paying for caregiver training. Again, very important for people with serious illnesses like diabetes, as well as paying for social determinants of health risk assessments. So really, there's quite a bit that we're doing to try to, expand the scope of how people view healthcare and how we pay for healthcare, so that we really can keep people healthy, which is ultimately our goal. Now, you may know that Medicare has both that fee-for-service side and also the Medicare Advantage side, where we partner with private health plans to provide Medicare. And there also, we have taken several important steps to make sure that Medicare Advantage is addressing issues of health equity, is really supporting people with diabetes and others who rely on the Medicare program for their health. Things like streamlining what's called prior authorization, where previously there were many barriers to being able to get care. Now, a health plan has to follow the coverage decisions of the traditional Medicare program to make sure people have access to reasonably medically necessary care. And we're doing a lot to crack down on misleading marketing practices. So again, as we are in open enrollment, so that people can really pick the option that works best for them and for their health, which is really important for people who have something like a condition like diabetes, to be able to see what can help them to stay healthy. So these are just some examples of our broader changes to the Medicare program that are really geared towards improving access, equity, and quality in Medicare.
Thank you so much for that. We will now transition to bring in our panelists, but I really hope you'll weigh in throughout our panelist discussion with your expertise on all the policies you just detailed, and also as a surgeon and physician treating patients, as you mentioned. So now I'd like to briefly introduce our panelists, who I invite to come on to camera for the next part of our discussion. First, I'd like to introduce Meena Witt-Glover, who's the Executive Director for the Council on Black Health, an organization whose mission is to advance solutions that promote health in Black communities. Dr. Witt-Glover is a scholar, researcher, and community partner known for her expertise in public health, program planning and evaluation, and health interventions in racial and ethnic minority communities. Welcome, Meena. Next, we have Dr. Eric Sullivan, who is a family medicine physician in Chicago. He provides primary care to patients of all ages and teaches medical students and residents. He currently serves as the chair of the Access to Affordable Care Impact Area at Doctors for America, a national organization dedicated to improving access to equitable, high-quality, affordable health care. He also serves on the Commission on Federal and State Policy with the American Academy of Family Physicians. Thanks for being here, Dr. Sullivan. And finally, we have Reverend Siobhan Arline Bradley, who is an ordained minister and the CEO of NCNW, an organization dedicated to leading, empowering, and advocating for women of African descent, their families, and their communities. Siobhan has more than 20 years of experience leading initiatives on healthcare, government affairs, equity, diversity, and inclusion, including senior roles at the U.S. Department of Health and Human Services and the NAACP. Thank you so much for joining us. So first, I want to start with a question for Dr. Witt-Glover. The Council on Black Health places a large emphasis on trusted messengers in the community. The idea that health workers and individuals within the community with cultural competence are really the most trusted to deliver information on new benefits like the ones that Dr. Seshamani mentioned. Can you speak a little bit more about your work on this and the role of trusted community messengers when speaking about new policies?
Sure. Thanks for the question, and thanks for inviting me to be a part of the panel. So the Council on Black Health does our work through three areas: research, policy, and practice. And as a part of the practice work, we have been engaged in identifying people in communities who are trusted. They are the people that within communities, when your care provider tells you something, you might go to these individuals to say, is this the right thing? Did you get the same information? Was this your experience as well? And so some of the work that we've been doing is to equip those folks with the appropriate information to be able to deliver information that's true and trusted to people in communities. And I think that's really helpful to make sure that those folks are equipped to be able to sift through information that might be misinformation, and also to be able to share, making sure that those folks understand benefits that are available, understand new programs is also important, because not only can these trusted messengers understand the new programs, but they also understand the context in which people live and can help people figure out how do you fit the information that you're learning about these new benefits into your life so that you can actually use them, which is a little bit different than saying, here's a list of things you're available for, go for it. And so I think that those trusted messengers have really been instrumental in our work and helping people not only to understand benefits, but really to be able to utilize them.
Thank you so much. And Dr. Sullivan, as a provider, you are often that trusted messenger that's directly interacting with patients and managing their care. Can you speak directly to some of the challenges faced by people with diabetes that you treat on a day-to-day basis, and why lowering health costs is important for this population? And Dr. Seshamani, I hope you'll add to this question following Eric's response as well.
Yeah, thanks, Sarah, and thank you to you and Dr. Seshamani for having me on the panel. Really excited to be here. So yeah, I think happy to talk about the challenges that are faced by patients with diabetes. The thing about diabetes is that it's very widely known in popular society. Like, a lot of people have heard of diabetes, but I found that when you actually are going to tell someone that they have diabetes, there's so much to it that people don't necessarily know. And that often, for me, often requires like a full extra visit after I've diagnosed with someone with it. Like, hey, your blood sugar is high. We need to have a conversation about what it means to have diabetes. Because diabetes for people can be almost a full-time job. There's a lot that goes into managing diabetes, whether you have type 1 or type 2. There's obviously managing your blood sugar levels, whether that's with oral medications, with injectable medications, with insulin, and then, monitoring, whether that's with finger stick pokes, a continuous glucose monitor, even just keeping up with all the technology can be overwhelming, even for us physicians, let alone patients who don't have medical training. And so I think, one of the challenges or like the litany of challenges that patients face is just even coming to understand like what is all involved in their disease. And I think that gets lost a lot of the times when we talk about diabetes, because it is just so well known in kind of the popular sense, but the actual intricacies are so multivariate that when I sit down and have that conversation with people, it can often be overwhelming for them. And I think it sometimes takes a while to get, to really feel comfortable managing their disease. So I think that when it comes to all of the things that I just mentioned, I think I rattled off a lot of things there that someone could reasonably have to go out and purchase, whether that's medicines, diabetes supplies, needles, machines to check your blood glucose. All that is unfortunately very expensive, and for a lot of patients with diabetes who are either on a fixed income or have a low income, these things can eat up huge chunks of their monthly income. And so regularly I'm having conversations with patients about, okay, what can we do to work within your means to make sure that we're keeping you safe and healthy while managing your diabetes? So this was already a topic that, unfortunately has been familiar to me since, day one of my training as a primary care physician. And so it's just an absolutely monumental step to take to start to lower these cost barriers for patients with diabetes, because it was already just such a huge part of the challenge. And so anything that can be done, whether it's on the medicine side, whether it's on the supplies side that patients are using, or even things like vaccines, like Dr. Seshamani was talking about, of which diabetes patients often require significantly more than the average patient at a given age. All of that adds up, and anything we can do to lower that barrier is just so critical for almost everyone with diabetes.
Thank you. And Dr. Seshamani, do you want to add anything to that?
Yeah, I mean, I think that what Dr. Sullivan said really encapsulated what we've been talking about so far on this panel. It's so important that we reduce cost barriers because we know that is a huge driver of inequities, but also to really see people as people, that diabetes affects all aspects of your life. And that's why, Sarah, I was glad that you asked me about other things we're doing. In addition to lowering insulin so it's no more than $35, being able to support community health and care navigation and, complex care, that's what, and being able to partner with trusted messengers. That's the only way that we're actually going to be able to drive meaningful change in communities. I'm an ear, nose, and throat doctor. So a lot of times people are like, well, what do you have to do with diabetes? I had one woman who came into my office, I think for like ringing in the ear, but I was reading through her chart and she was actually in our diabetes care management program. And we got her hemoglobin A1C from 13 down to 7. So I went in to go see her and I said, before we talk about your ears, can I just give you a high five for, how you have done this? She said, Doc, don't give me a high five, give me a hug. And then started telling me basically about how, the program changed her life. Because again, it was not just about a needle stick or, like a finger prick. It was about like looking at like her as a person and like, changes to her lifestyle and like getting family supports. And that's what makes a difference for people. And that's what we are, the drug side is an extremely important aspect of it. And to what Dr. Sullivan and Dr. Whitt-Glover have said so far, it really is about also just looking at people as we do this.
Thank you so much. And now I appreciate you mentioning, seeing people as people and how sometimes these benefits are even complex to providers themselves to keep up with. And so it's really important for the trusted community messengers. And we will shift to talk about how that can really move the needle on health disparities in a moment. But first, Reverend Arline Bradley, I want to remain on this question of trusted messengers for just one moment, because as an ordained minister, you can uniquely discuss the importance of engaging with faith communities and other community partners when raising awareness about diabetes and new benefits like the ones we've discussed.
Well, thank you all for having me. I will say I'm really proud of this conversation because I was at HHS a few years back and just recall the commitment to engaging faith leaders. I know through the work that I've seen over the last few decades, faith communities have really stepped up. I was around in the early days when REACH started in the CDC, when we were working on racial and ethnic approaches to community health and trying to identify the best opportunities for partnerships with faith institutions. Now, fast forward over 20 years later, we're talking about an institution that has been a staple in many communities. Very, very strong in the Black community, very strong where we have synagogues, we have temples, we have mosques, we have churches that are really seeing themselves as a part of a solution. And let me just say this about faith institutions. These are I believe, perceived as some of the safest places for conversations just like this, for conversations about how an entire person's lifestyle can be affected by their health, by the choices that they're able to make or not able to make. And it's really important to say that some are not able to make healthy choices. And so as you think about the public health perspective, I just left APHA and we were having this same conversation around determinants. And we consistently have to go here because these are some larger systemic issues that we're seeing. Faith institutions have been a place that also highlight how do we help heal the whole person's experience. So it's not just about them just eating right or just getting physical activity. We're talking about now, well, do you have access to a built environment that allows you to be physically active? Is there an opportunity for you to have gardens of fresh vegetables where you live? Or is there an opportunity for you to have family time? Do you live in safe neighborhoods to be able to engage in physical activity? Well, faith-based communities have actually opened centers, have opened up their doors to opportunities. And so it's really important to highlight that in this discussion.
Thank you so much. I really like that that this is one of the safest places to deliver information. And we will be sharing some resources and information at the end of the call, because it's not just providers, but community members and faith leaders and caregivers are a really important part of this to make sure they have accurate information at the right time. And Reverend Arline Bradley, I want to stay with you for one moment, because one of NCNW's 4 major priorities is health equity, and your first tier on your priority page is affordable care. And so can you talk about why addressing affordability is so linked to your work to advance health equity?
Well, it's really important to know what equity means to us. As we're advancing health equity, the way that we define it, we're in partners with our friends over at Robert Johnson Foundation and others who have really worked on defining this, but I try to simplify it for people. And it is to really remove anything that stands in the way of an optimal health experience, right? So that can be barriers, that can be access to care, that can be transportation, that can be cost. But in order to achieve health equity, we must remove those barriers that stand in the way of that most optimal experience. Now, it's important for NCNW because we serve a segment of a population that has consistently been holding the bag on healthcare for their families, right? So women, their families, their communities have really been in the forefront of how do we ensure our communities understand what does it mean to have access? Well, cost has been a long-term barrier for many communities in this country. And the importance of this moment, as I want to applaud the administration in this process, it is imperative to think about how costs can be cut to ensure that making decisions about your health care are not affected by you having to make decisions about your livelihood. We don't want you to have to cut your rent, or we don't want you to have to choose food or my insulin. This is why this opportunity for NCNW was so important to join. We want our members and your listeners to understand that cutting costs is one of the first steps towards seeing changes in behavior, because it makes things more accessible. And so that's why our organization is committed to this. That's why we're here, but it's also why we're calling for leaders across the country to tell the story about what benefits are available with this provision.
Thank you so much. And I want to ask Dr. Whitt-Glover and Dr. Seshamani to build on that a little bit and just talk about the potential for new benefits to really move the needle on health equity and the importance of implementing the law in a way that it really does move the needle. So I'll start with you, Dr. Seshamani, and then go to you, Dr. Whitt-Glover.
I mean, I don't know what else to add after Reverend Arline Brady. I mean, I think everything she said is spot on. I mean, people have to choose between their rent and their medicines, or then feel that like people don't understand what they're going through. Like you have someone saying, here, just go fill this prescription and take this medicine. Well, like, do you have any idea what my life is like? Right. And so I think it's so important that we are showing, no, we want to wrap our arms around you. We do understand. And that's why it's not just about, me putting out a 2,000-page payment regulation. It really is about that partnership, so that on the ground, these things are coming to life, and looking at it from all of the angles to be able to support people. So, I mean, I say that, we made vaccines available at $0. 72-year-old grandmother, if she doesn't know that she can go get her shingles vaccine at no cost, but she's not just going to randomly go to the CVS and be like, hey, I just thought I'd check, right? I mean, like, it's so important that we are telling people about the changes that are occurring so that they know what they can get access to, and then helping them to get that access, like really supporting them, finding out, like, are you able to get to a pharmacy, to get that vaccine, or, and that's why being able to pay for community health and navigation is also important as well.
Thank you. And Dr. Whitt-Glover, do you want to add to that?
Not so much to add. I mean, I think the two previous speakers said it all. What I will just say is that these types of benefits and policies just provide the opportunity for everyone to have all the tools available to them to be able to treat the disease. And so by making insulin costs, making drug costs affordable, it means that you are no longer shutting a certain segment of the population off from being able to have the appropriate tools that they need. And I think that's critical. Everyone may not need medication, but to not have access to it just provides, just gives people, just makes it more dangerous for people. And so I think that is incredibly important, just to make sure that everyone has access.
Thank you so much. And now to shift back to you, Dr. Sullivan, and the provider perspective, because I hope we have a lot of providers, and not just physicians, nurses, social workers, community health workers, navigators. You have a really active role in this. And to talk not just about insulin, but also Dr. Seshamani mentioned there's 4 drugs selected for negotiation that treat type 1 and type 2 diabetes, but there's a lot more that's important for patients like the ones you treat, like free vaccines, expanding the extra help program, and having cost cap. Can you talk about why those provisions and not just the insulin provision are really important for your community that you treat?
Yeah, absolutely. I think, Dr. Seshamani was mentioning, I mean, vaccines, I think alone are one of the biggest game changers in the Inflation Reduction Act. I remember frequently during my training where I worked in a federally qualified health center, we would have patients come in who we saw, it looked like they were not up to date on any of the recommended vaccines that they needed for their diabetes. And, as we would talk about them, inevitably the conversation would turn to cost. And, we would have to tell them, each of these shots, and sometimes it's a 2 or 3 dose series, would be in the hundreds of dollars. And, these would be patients who were living at or below the poverty line at times. And so, that was just an impossible barrier for them. And there really wasn't, unfortunately, much we could do to help them. So when I saw that the Inflation Reduction Act was including a benefit for recommended vaccines at 0 cost, I mean, that was something that I could just immediately call back to and think of all the patients that would have benefited from this in years gone by that we had to let walk away without giving them the recommended vaccine. So that alone was very exciting. But I think the other aspect that I'm most excited about is the price cap on the out-of-pocket payments for total medications that's coming in a couple years, because I think even in the diabetes space alone, to say nothing of some of the other high cost medications and treatments that will eventually be affected by this, but even just in diabetes, when we talk about treating diabetes, obviously everyone first thinks about insulin, and insulin is obviously a life-saving drug, and for people with certain types of diabetes, insulin is the only option we have. But in the last 20 years, there's now just a wealth of new diabetes medications that can actually completely eliminate the need for insulin for many patients, particularly type 2 diabetes patients who may not need insulin at all. And that's really a huge improvement for them, because insulin, despite obviously being life-saving, has many side effects, some of which can be very dangerous, potentially dropping blood sugar to levels that can induce unconsciousness. And so, when you talk about Medicare patients who might be, also suffering from other diseases or getting older, may not be able to, manage their insulin quite as effectively. If we can get them onto other medications that are going to take away some of that risk, I mean, you're talking about potentially life-saving benefits just from making that switch. But unfortunately, some of those medications like Jardiance and Farxiga, when I would go to prescribe them for my Medicare patients, they would come back to me at the next visit and say, "Doc, I never filled that prescription because I went to the pharmacy and I just couldn't pay for it. So, I just had to keep doing my insulin." And to have this price cap in place, and then of course, the Medicare drug price negotiation that's ongoing, to potentially bring those drugs down into the affordable level, I think is an underappreciated aspect of the law that is potentially going to get a lot of people off insulin and onto these safer, newer medications. And a lot of people will benefit from that. And so I'm very excited about that prospect.
Thank you. I appreciate it. Thank you all for such an insightful conversation. Before we turn to see if the audience has questions, I wanted to hand it back to Dr. Seshamani, who touched on this a little bit before. We've talked about some of the benefits that are already in place, but I'd love to talk about what's coming in January and the years to follow, and also to highlight some of the resources that CMS has put out about insulin. And I will screen share as you're touching on those, and I'll add to any that you may forget. But let's begin with some of the new benefits that are coming this January.
Yeah, absolutely. So as we mentioned, starting in January, the Extra Help program, the financial assistance program for Medicare prescription drugs, is expanding. So people who currently are only eligible for partial help will be eligible for full help. And so it's really important, especially we're in open enrollment, to contact us and see if you could be eligible for that financial assistance. And the other big change starting January 1st, 2024, is that when you have a high cost drug and you hit the catastrophic phase of your prescription drug benefit in the Medicare program, you no longer pay anything out of pocket, which is huge for people who are taking high cost drugs, like Dr. Sullivan was talking about, that there may be a limit to what they pay. And I think, as we have been talking about on this panel as well, it's so important for everybody to be getting the word out, to be answering people's questions, to make sure that everybody has access to this information and knows what they can take advantage of. And so that's why we have several resources that I think Sarah's going to screen share to be able to share with all of you, because honestly, it takes a village. And it is so important that we all work together to make sure that we're getting the word out for everyone. So, the first here is, an example of what we have that can be distributed on insulin. Learn more about your coverage, gives the 1-800 Medicare number so that people can find out more. And again, to be able to use these to be able to distribute to your local communities. So that's one. If you want to go to the FAQs as a next one, we also have frequently asked questions. So this is really helpful for, again, pharmacists, other healthcare providers, people who are like ship counselors, like doing, insurance navigation for us, people to be able to see, okay, like if you're getting more specific questions, to be able to help people in navigating and understanding what exactly the $35 cost sharing cap means. So we've got, a variety of frequently asked questions on our website as well. And then the third is a drop-in article. So this is something that you can take and insert into whatever, flyers, distributions that you're sending out to your communities, your membership. So it's a drop-in article that can be put into any newsletter, etc., electronic, paper, whatever you want. So all of these are available on our website, and we'll be sure to give you the links to them, because again, this is only going to reach as far as it does with partnership with all of you, so that we make sure that everybody knows about this and goes to take advantage of it.
Thank you so much, Dr. Seshamani. And HHS is also planning on distributing this new poster to you all. Anyone who's registered, we will send all of these links packaged to you following this event. And this is a poster that we hope folks like Dr. Sullivan will hang in your waiting room, in your exam room, in your community health center, just to really have all the information in public places where you all are sharing information with partners and caregivers and patients. So now I want to shift to a couple questions we have from the audience. I will start with one that anyone should feel free to take, but I'll start with Dr. Sullivan as a physician. Can you talk about why it's important that folks who take care of diabetes patients every day know about new benefits?
Yeah, I mean, I think Dr. Seshamani and our other panelists have touched on this, but unfortunately, the reality for healthcare in America these days is that too many patients have to be bringing cost consciousness into their doctor's visits. And so it's a rare day where I don't have multiple visits where patients are coming to me and saying like, doc, but how much is this going to cost me? Like I haven't hit my deductible yet. And so it's just not, as a, primary care provider, really any provider in the healthcare system, it's just a key part of our responsibility now to have a better sense of what are the financial responsibilities that are going to fall to patients. And so anything we can do to lighten that load by being aware of the benefits that are out there, I think is literally going to translate into lives saved, because if we can get even just 1 or 2 more patients able to take, their life-saving treatments, that's a game changer. And so, I think it's just incumbent upon us as medical professionals to put this into our toolkit with all of our other biomedical knowledge, to be aware of programs like this and to be pushing for more, quite frankly, because, this is a great start. But there's many patients out there who are not going to be covered by these benefits. And so we as providers need to be aware of whatever's out there to help our patients get the care that they need.
Thank you. Do any other panelists want to add to this question? Okay. This next one I think is for Dr. Seshamani. Does the drug cost law, the IRA, include Medicare Advantage?
Thanks for that question. So the majority of the provisions in the drug law are with the Medicare prescription drug program, which applies for both Medicare Advantage and traditional Medicare. There are a few provisions, like most insulin that you get in a pump, that if you have Medicare Advantage would come through your Medicare Advantage plan. That is also, included in the new drug law. So yes, if people are on Medicare Advantage or traditional Medicare, you should see these benefits that we are talking about.
Thank you. And this one I think is also for you. Can you tell us how the federal government is paying for all of these lower costs for Medicare beneficiaries?
Well, it's a great question. And I think this is where, as the legislation was put together, that you have provisions like the inflation rebates that we haven't talked about, where if drug companies increase the prices of certain drugs faster than inflation, they have to pay the difference back to the Medicare program. You have drug negotiation as well. So, and I think we all know also that keeping people healthy makes sense. So, I think overall, it is about spending money in a smarter way so that we can provide better care and we can improve the health of our populations.
Thank you so much. I appreciate that. I believe we have one more question, and this is to any panelists, but we talked a lot about getting information directly to patients. Can you speak a little bit about the importance of caregivers? There's a lot of course, intergenerational caregiving. There's the trust messengers we talked about. I'll start with, I believe I'm remembering that one of you all has a really cool community health workers training program. Can we talk about the partnership between community health workers and caregivers? And for any of you, the importance of engaging caregivers in this conversation?
Sure, that's I think that's me with the Council on Black Health. We have a community health worker, a trusted health navigator training program. And the folks that we identify to go through those programs are people who have lived experience as a part of population subgroups who may not be reached by some of the messaging around health. And so we bring those folks in and we provide the typical community health worker training, which is about 100 hours, and then a practicum experience. But the idea is that those folks then have the basic information about what we want to have people communicate, and then we ask them to translate it for their population subgroup. And a lot of times when we say translate, we think translate into a language other than English, but translate could also be translated into cultural nuances that help people to understand the information in ways that their population subgroup receives it. And so we found some success in being able to take key information, like I love the examples that you dropped into the chat, the links that you dropped into the chat. We will certainly be using those and passing those on to our community health worker population. But then we share that information and we say, okay, now keeping the same message, the key elements of the message, do what you need to do to break this down so that people from your population subgroup can receive it. And I think that's a really, really important and really helpful way for those folks to be able to get the message out, to be able to carry the information back to people in communities. The other thing that I'll say that's important about that, I'll just use barbers as an example. One of the trusted health navigator populations that we work with is barbers. And they talk about the fact that they see people across generations. So one barber that we talked to mentioned that he has been working with someone that he has cut this person's hair, this person's son's hair, and now this person's grandchild's hair. And so this one barber has been engaged in this person's life for 20, 30 years. And so he knows that family. He can provide information as a trusted navigator in ways that probably none of us on the call could provide. And that's an effective method of communication. He's not a care provider, but he is a person who is a caregiver who cares about this family, knows all the nuances. And so I think those kinds of examples and opportunities to connect with people in communities as trusted messengers are important.
Thank you so much for that example. And does anyone else want to add to this question of the importance of engaging caregivers and not just the patient? All right.
I can chime in. I am just so heartened and filled with hope by this conversation, and that we are talking about caregivers, right? As a critical part of how we can care for our communities. And I think I mentioned, Sarah, when you had asked earlier, Medicare starting January 1st is going to be paying for caregiver training, because we see the important role that caregivers play in keeping people healthy, especially people in the Medicare population. So, again, I think as we are, thinking about all of these resources and distribution, it's exactly as you all have said, it's not just distributing to the people with diabetes, it's distributing to the communities, because everybody, if 1 in 3 people in Medicare have diabetes, 1 in 10 people in the country have diabetes, we all know someone who has diabetes, right? And it's incumbent on all of us to share information and to support each other.
Thank you so much, Dr. Seshamani. And before I reiterate some of these resources we've discussed, do any of the panelists want to add any closing thoughts today on World Diabetes Day? Right.
Sure. I'll just say thank you again for having this conversation. As we've talked about, I think I would just encourage patients, community members out there to reach out to your provider, hopefully a primary care physician that you have a long-term relationship with, because that's what they're there for, is to start having these conversations and asking them, like, hey, I haven't been taking care of myself, or I haven't been able to take care of myself because of barriers in my life. Like, what's out there now? Like, what can I be doing? Because the physicians in your life are there to help you and want to get you into a better place. And so thanks to programs like this, and hopefully more to come in the future to benefit the rest of the population not currently served by Medicare, we're slowly chipping away at some of those barriers and hopefully getting us that much closer to healthcare as a right in this country. So don't be afraid to reach out to your doctors and ask them to do a little bit more for you.
Thank you. All right. Well, we are about at time, and I just want to thank our panelists so much for sharing their expertise and insights, and to all the participants who submitted questions. Please be on the lookout for a follow-up email. The insulin postcard, the insulin FAQs, the drop-in article, and the insulin poster. We are going to share those with you in the hopes that you share them with your communities, as many of you are providers or trusted messengers or caregivers. So with that, please be on the lookout for those resources. Thank you, everyone, for joining us, and have a great day.
Produced by the U.S. Department of Health and Human Services.